Yes, so hopefully I have time. Can you reset the clock? 20 minutes? Yeah. So hopefully we have time to discuss few cases. The first case is easy, hyperkalemia. So we had a 62-year-old female with end-stage kidney disease. She presented with weakness. Her vital signs were more or less normal. She was somewhat confused, and you can see her labs: sodium 138, bicarb 24, chloride 104, potassium 9.8. I had never seen such a high potassium. So first thing you always think is that a real potassium or is it fake potassium? You may repeat the test, but you should also do an ECG, because at that level you will see ECG changes. But if it's a spurious or so-called pseudo-hyperkalemia, then you may not see ECG changes. So here you can see wide complex QRS and elevated T waves. The P waves, I think, have kind of disappeared. So anyway, this was a case of acute hyperkalemia in a patient with end-stage kidney disease. So how do you treat this acute hyperkalemia in end-stage kidney disease? The first thing, of course, you have to do dialysis. But by the time you bring the dialysis nurse from home at night, and by the time she prepares the machine, it will be 3-4 hours. So most likely your patient is dead. So you need to take medical management. So the first step is to protect the heart, right? So you can either give calcium chloride or calcium gluconate, and it basically reverses the effect of potassium on the heart, and it modifies myocardial excitability. It's important to note that the onset is nearly immediate and the effect lasts for about 60 minutes. You can also give insulin and glucose. If somebody's sugar is high, there is no need to give glucose. In that case, you can only give insulin. The onset is not immediate. It takes about 5 to 10 minutes. You can also give albuterol inhalers. They tend to push potassium into the cells. It takes obviously a longer time for action. The duration is about 2 to 6 hours. So it's you can use it, but it doesn't have an immediate effect. And the most important treatment is urgent dialysis, especially if your patient is oliguric. While you wait to start dialysis, if your patient is not making urine, there is no point in giving Lasix or furosemide. In non-oliguric dialysis patients, you can try Lasix or furosemide, as it may get rid of some fluids and some potassium may go out. Okay, so that is how you treat hyperkalemia in end-stage kidney disease. And here you can see that the immediate, you can see obviously calcium works immediately, insulin comes second, bicarb, and then oral anti-hyperkalemics. But the treatment for this is basically doing dialysis. What is important is when you do dialysis in patients with renal failure, the dialysis only removes a certain load of potassium. So in a 4-hour session, you may remove around 200 to 400 millimoles of potassium. So there will be a rebound hyperkalemia. So it may be safer after like 8 hours to check their potassium again. And if it is high, you may need to do a second session of dialysis, right? So don't be satisfied with one session of dialysis, recheck the potassium, and if needed, you may have to do a second session of dialysis. Now, the second case, I think I presented about a couple of years ago, this case. There is a 54-year-old gentleman. He was complaining of headache and lethargy. His plasma sodium was 113. His urine osmolarity was 580. Plasma osmolarity was 232. So that was low, right? So the renal, adrenal, and thyroid function was normal. He was on bupropion. Physical exam, euvolemic. So the diagnosis, anybody? What's the diagnosis? No clue? Hyponatremia, right? And I've given you all the clues, right? Number one, he's euvolemic. Number two, does he have SIADH? I don't know, but One of the exclusion criteria is you must have normal renal, adrenal, and thyroid function. So he has the normal renal, adrenal function. So maybe he has SIADH or elevated ADH. Now, how do I know he has elevated ADH? Because normally when you become hyponatremic, your urine osmolarity should go down. But if your urine osmolarity is high, especially more than the plasma osmolarity, it means that there is ADH stimulation. And whenever there is ADH stimulation, you will reabsorb water and you will get hyponatremic. Now, this patient's urine osmolarity is high. It's more than the plasma osmolarity. So I know that he has ADH stimulation. So most likely he has inappropriate ADH excretion. And in this case, it is due to a medication called bupropion. Now, how would you treat this? Any suggestions? How do you treat acute, I would say, symptomatic hyponatremia? Hypertonic, yeah, correct. So hyponatremia is a very common electrolyte abnormality. All of you will see it in the hospital. Also, just remember that hyponatremia is normal in pregnancy. We classify hyponatremia based on the symptoms or on the level of sodium. So the treatment of hyponatremia is basically to give hypertonic saline, right? So in the UAE, I know, and in the US, we give 3% saline. I also worked for some time in the UK. They have like different kind of solutions in the UK. It's a bit strange over there. So anyway, hypertonic saline 3% is kind of standard. What is hypertonic saline? It's basically 1 liter of water with 500 of sodium and 500 of chloride. So if you see at the bottom, what that means is 1 ml of this solution has 0.5 of sodium, or 2 ml of this solution has 1 millimole of sodium. So if you're targeting your patient to go from a sodium of 113 to 120 in the next 24 hours, first you calculate the sodium deficit. That is the amount of sodium you need to give in 24 hours to increase the sodium from 113 to 120. So that is 0.6 times body weight times the target minus current. That is around 300 millimoles of sodium. So if you give this patient 300 of millimoles of sodium, his sodium will rise from 113 to 120. And since you're giving it over 24 hours, so per hour, you have to give him 12 millimoles of sodium per hour. Now, if you move to the right, I told you that 1 millimole of sodium is 2 ml of this fluid. So if you want to give 12 millimole per hour, you have to give 12 times 2, that is 24 ml of 3% sodium chloride. Okay, so I hope you understand how the nephrologists give 3% sodium chloride. And I would suggest don't use the formulas which you get online. I would suggest you try and do it by this method because it's more academic, yeah? That differentiates you from a physician from a nurse, right? There are also other kinds of fluids available. Sometimes you get 1.8%, sometimes you get hypertonic. What I can tell you is you can use any hypertonic fluid as long as the osmolarity of that fluid is greater than the patient's plasma or urine osmolarity. So in the previous case, if I had used 1.8%, I would have gotten away with it because the osmolarity of this fluid is 616, which is greater than the patient's urine osmolarity. But if the patient's urine osmolarity was 800, then I would definitely have to use 3% saline. I wouldn't use 1.8%. And in the long-term management, basically, hyponatremia means you have an excess amount of water relative to salt. So you have to increase the urine volume. So you can increase urine volume by 2 methods. Number one, increase the number of osmoles in the diet, or you can reduce the urine osmolarity. So increasing the osmoles in the diet is basically by giving sodium chloride tablets high protein diet or urea tablets, and decreasing the urine osmolarity is with furosemide, and occasionally we use Vaptans. And these are the guidelines of hyponatremia, but basically it's complicated, but you're safe if you correct hyponatremia between 8 and 10 millimoles in the first 24 hours. Yeah. Sometimes you can even correct 5 millimoles, and that's enough, right? Because the brain is usually symptomatic when it expands by 5%. And if you reduce the plasma sodium by 5 millimoles in 24 hours, you're more or less playing it safe. And this was a real life case where the emergency physicians corrected sodium very quickly, and the patient got osmotic demyelination syndrome. And the bottom two slides show the CT scan, and you can see the white areas are the demyelination. So quickly, I don't have much time. Let's go to the third case. So I want to talk about alcohols. Alcohols are complex electrolyte disorders. The most common you will see is methanol and ethylene glycol, because you see mostly laborers, they are in contact with ethylene glycol or antifreeze. They have a lot of issues, financial, social issues, and they start drinking this. Fluids, most of it is intentional. So first of all, when you see this, you need to understand what is anion gap and osmolar gap. So anion gap is basically sodium minus chloride plus bicarb, and osmolar gap is the difference between your calculated urine osmolarity and the measured urine osmolarity. Now, calculated is what you do by yourself. It's usually 2 times sodium plus 10, and the measured is what your lab measures. So your lab will measure not only the sodium, glucose, and urea, it may also measure the non-calculated alcohols, which you are not able to calculate or measure. So they may calculate the level of ethanol and ethylene glycol. So here you can just see the anion gaps are of 2 major types, the non-anion gap and the anion gap metabolic acidosis. One of them is associated with low bicarb, and the other one is associated with a normal bicarb, but a compensated elevation in the chloride level. The osmolar gap is just the difference between the measured and the calculated osmolarity, and if the difference is more than 10, that means you have some osmotic substance which you haven't calculated, but the machine is measuring. So methanol and ethylene glycol are the 2 important compounds that cause both metabolic acidosis with an anion gap. And it's important to note that ethanol may increase the osmolar gap, but it doesn't cause metabolic acidosis. So here you can just see a case of 55-year-old man. He presented with the following labs: sodium 144, potassium 4.7, bicarb 9, creatine 240, urea 34. The ABG shows metabolic acidosis. The anion gap is raised 31, and the lactate is high, around 20. So his measured osmolarity was 345 and calculated was 300. So he had a big osmolar gap, right? So he has an osmolar gap with an anion gap. So the 2 things that should come in your mind is methanol and ethylene glycol. And here you can see there is ethylene glycol crystals in the urine. So these patients are very fragile. They will come in very normal, and within 4 to 6 hours, they will decline. They will have confusion, seizures, and they may have renal failure. The treatment of this is giving them fomepizole, which blocks the breakdown of the alcohol, and to do immediate hemodialysis. Myself, I prefer to do what is called CRRT, which is continuous dialysis for 24 hours, because then you're continuously removing the alcohol from the system. They're also prone to develop seizures. Outcomes occasionally are poor in these patients. They may recover neurologically, but in terms of renal recovery, it's less than 30%. Ethylene glycol is rapidly removed by dialysis, so it's the treatment of choice. And here you need to understand the chemical changes that happen when you follow these patients over time. So ethylene glycol initially causes a high osmolar gap. So when you see these patients, they will have a high osmolar gap and they don't have an anion gap. But as ethylene glycol is broken down into acids, the osmolar gap will be reduced, but the anion gap will increase. Yeah? So that is the trend that happens over the next few hours. So it's broken down into oxalic acid and formic acid, and oxalic acid will bind to calcium in the urine to form calcium oxalate crystals that will cause you to have a renal failure. So this graph clearly shows, you can see on the left, as time progresses, first the osmolar gap is high, the anion gap is normal. Then as the alcohol is broken down, the osmolar gap declines and the anion gap increases, right? The alcohol is responsible for the CNS depression. The acids are responsible for renal failure. And why did this patient have a false high lactate, right? They don't have like liver failure and they're not hypotensive, but they get a high lactate because some of these acids, the glycoxylic acid, is measured as a lactate. So if you use the old type of meters, it is falsely measured as a lactate. But if you use the new meters for checking the alcohols, it will not be misread as a lactate. So in about 20 years ago, we used to have what is called a lactate gap. And the lactate gap, if you measured it with what is called a radiometer, will give you a high lactate. But if you use the iStat machine, that's the portable machine, you used to get a normal lactate. So if there was a high lactate gap, it was used as an indirect measure of ethylene glycol toxicity. So just for the sake of time, you can see that when you have an anion gap with an osmolar gap, think about methanol and ethylene glycol. When you only have an osmolar gap, think about ethanol and isopropyl alcohol. And this is just another slide showing the same. For the sake of time, this is the last case I want to show you. We have a 42-year-old male. He presented with headache, right-sided weakness, blood pressure 230 over 118, serum creatinine, which was normal, was 211. So any clues? What's the diagnosis? Yeah, I would say there are lots of definitions, but I would say a hypertensive emergency. Yeah, there's lots of there's malignant hypertension, hypertensive encephalopathy, hypertensive urgency, and emergency. But I think we should try and make it simple. You call it an acute hypertensive disorder. A hypertensive emergency is when you have a high blood pressure with acute end organ damage. This patient has right-sided weakness like hemiparesis and acute renal failure. So I would classify him as hypertensive emergency. If he didn't have acute end organ damage, then I would classify him as having a hypertensive urgency. So I think if you use this definition, it's more clearer to me if you were to call me. Yeah. The acute end organ damage can be different types: dissection, pulmonary edema, renal failure, stroke, hemorrhage, and what we call hypertensive encephalopathy. So it's important to note that in this case, you need to reduce the blood pressure in hypertensive emergency with IV medications, not oral medications, and you need to target a reduction that is less than 25% and try to bring the MAP to around 110 and 115. The only exceptions where you try and bring it to normal is in aortic dissection because they are at risk of rupture, and in the case of eclampsia. If you reduce the blood pressure very quickly, then you're at risk of an ischemic event, especially ischemic renal and cerebral event, and even blindness. The medications we use commonly, I like to use IV labetalol. It has a quick action. You can use nicardipine in CNS events because it doesn't reduce intracranial pressures. Don't use IV nitroprusside because it increases intracranial pressure. So if they have a cerebral event, try and avoid IV nitroprusside. But otherwise, you can use any of these drugs. Hypertensive encephalopathy is basically a syndrome where you have a high MAP It's often associated with cerebral hyperperfusion. You get more CNS symptoms like headache, nausea, vomiting, confusion, signs like papilledema. The treatment is also to reduce the mean arterial pressure by not more than 20%, and aim for a diastolic blood pressure. Important in hypertensive encephalopathy is before you stop the IV medication, make sure the patients are on oral medications. Some drugs may induce hypertensive encephalopathy, especially when you stop them. One of them is clonidine. If you stop clonidine, they get rebound hypertension and hypertensive encephalopathy. Thank you.